Okay, so continuing with chapter 13, this is going to be the second recording, hopefully until the end, but we'll see how my computer behaves, so it'll a little bit depend on that. I am going to be not quite as able to do the pen function because my pen is still charging, so I will hover the cursor where I need to and make up the difference in some short videos. So, this image is from the Netter's Atlas of Gross Anatomy, and that is, of course, the thing you use for lab. And this spinal cord segmental anatomy, so a cross section or horizontal section of the spinal cord, is in this picture in situ. So in situ, in space situ, means it is being represented or shown in its appropriate anatomical position with all of the surrounding structures that would be there normally. So this is nice because it gives us context so we understand things like based on this vertebra, which we can see, which is dorsal, because we can see the spinous process exiting here, and which is ventral, because that's on the same side as the body, and which things are transverse, etc. So in situ views of things are useful because it shows us positionally where the thing is oriented and in which direction. So the vertebral body is always going to be ventral, and the side with the vertebral laminae, here and here, and the spinous process are always going to be dorsal or posterior. So remember, because we're bipeds, our ventral surface here and our anterior surface are the same, and our dorsal and posterior surface are also the same. So this provides us with a nice view, and also this is like your models in lab where you have a vertebra surrounding your cross-sectional anatomy of the spinal cord to show you, kind of like where things are, which side is which thing, etc. So moving off of that, in the past PowerPoint and the previous lecture video, I described the conus medullaris. So conus means cone, medullaris means medulla, which is the core section of any multi-layered organ. So what that just means is like it's a cone that is comprised largely of the medulla of the spinal cord, and then basically it's the place at which the cord, which is a contiguous sort of rope of neurons with gray matter in the middle, ceases to be that rope. It comes to a conical point, and then after that, it is something called the cauda equina, which means horsetail. So after that, it's just a bunch of spinal nerves surrounded by a perineural sheath and running in parallel. So this is convenient for a variety of reasons, one of which is that if you need to puncture the cavity in which the spinal cord sits and take some fluid out of it, this is a good place to do it because you don't risk puncturing the actual cord itself here. If you use a blunt needle or a cannula, it's going to just move these nerves out of the way. You can safely sample the cerebrospinal fluid without risking stabbing anything important. So that's the reason why if you have a spinal tap, which is mentioned in this slide, it is performed medically using the procedure called a lumbar puncture. So there's a reason they don't select the thoracic spine for this procedure, and that is to minimize risk. We want to do it down here where as long as we use a blunt needle with the hole on the top rather than on the end, these nerves are just going to kind of roll out of the way and we can suck up some fluid and safely pull the needle out and not worry about damaging this person's innervations. Okay, so I mentioned epineurium and perineurium. So these are just the wrappings of nerves. And so, of course, spinal nerves, which is where the dorsal root and the ventral root converge, meaning that we have now a nerve carrying both afferent and efferent signals, so action potentials going in opposite directions. These need to be isolated both from the surrounding tissues and from each other, and they need to be padded and lined all the way through. So the connective tissue layers that you're seeing here are there for a variety of reasons. One is electrical insulation, so you want to make sure that the depolarization of one axon doesn't affect the depolarization of its neighbor. And also, an axon is a very long, delicate, fragile extension of a cell that is really just a long tube of cell membrane, and by itself, it's not especially sturdy. So if we want to successfully get an action potential from, for example, the sacral plexus all the way down to my big toe to do things like wiggle my big toe, that's a very long axon. So we need to wrap it in something sturdy so that it doesn't get broken up by the movement of my leg and my foot. So this is the reason why we have these repeated arrangements of connective tissue layers. And if you think back to our cross-sectional anatomy of skeletal muscle, you'll notice that it has the same naming scheme. So superficial most is epi, and then around each fascicle, also a muscular structure, is peri, and then surrounding each individual fascicle, in this case, is the endoneurium. So same naming scheme. So in this case, we have neurium, which means the layer that is on a nerve, instead of mesium, which is the layer that's on a muscle. And this picture, which you're seeing here, if you're not familiar with this kind of microscopy, this technique is called scanning electron microscopy. So what SEM, or scanning electron microscopy, does is basically it bounces some specialized rays off of a frozen piece of tissue and detects the electron density, which is a proxy for the molecule density of the given tissue. So you'll notice that, for example, the lumen here of the blood vessels is black, and that's because there isn't anything in here, and so there's no electrons to bounce anything off of, so it's a void. And then anything that does have electrons is going to show up, and depending on how densely populated it is with electrons, it's going to be brighter. So one thing to note is that this picture is what's called a false color image. So when you do electron microscopy, all of the pictures are just electron density, so they're just black and white. But they're often falsely colored in later, kind of like old-timey photographs that have been hand tinted, just so that you can make out the difference between various structures. So that's what you're seeing here. I think it's good to be explicit about what all of these things mean, because if you haven't seen one before, you'll have no idea of exactly how that image was obtained, if it's real or not, and then what it means. So let's go back through the connective tissue covering of nerves. Sorry, my cursor was misbehaving for a moment. So, quick reminder about nerves. We use different terminology depending on whether we're in the central nervous system, so brain and spinal cord, or whether we are in the peripheral nervous system, which is everything besides the brain and spinal cord. So, the word we use to describe bundles of myelinated axons wrapped in connective tissue traveling in the PNS, the peripheral nervous system, is nerve. So this is a very specific meaning. So the epi, meaning superficial, neurium, meaning nerve cover, is a connective tissue sheath that covers the entire nerve. And this is confluent, meaning the dura mater just kind of blends into this layer. So it's confluent with the dura mater. So it's not the case that as you exit the spine via the intervertebral foramen pictured here, you just stop having a meningeal covering or any covering at all. Instead, all of the special meningeal layers go away, but the connective tissue that makes up the dura continues to ensheath the nerve for protection. The perineurium, which is the word that means around or surrounding, and then of course neurium means nerve covering, this within the nerve takes bundles of axons, typically with a common destination, into fascicles. So it's providing structural organization. And then finally, the endoneurium wraps around individual axons. So I'll go over this more in one of the short videos, but if you're wondering, like, why do we even need an endoneurium by the time we get down to peri, it's pretty well protected. And the answer to that is electrical isolation. So think back to chapter 12 and think about what you know about how an action potential is achieved. What we know is the extracellular fluid has to be consistently high in sodium and low in potassium, and the intracellular fluid has to be the reverse of that. And the intracellular fluid also has to be, when the nerve is at rest, electronegative compared to the extracellular fluid. So, what that means is if one axon experiences a depolarization, the fluid outside of that particular axon is going to go from being sodium rich to being sodium poor as the action potential crosses that area of membrane. So if there was a neighboring axon that was not electrically isolated from our first one, the neighboring axon's capability to be excited would be negatively impacted by its neighbor having just depolarized. Because right after depolarization, the extracellular fluid is low in sodium and it's going to be high in potassium as that axon repolarizes. So if our neighboring axon is trying to fire, it's going to encounter a problem where it is trying to do its normal action potential activities, but the electrochemical gradient that is required for that is not present, and so it just can't fire. So one reason, and an important reason for the endoneurium, is just to make sure that the axons, even though they are traveling together in close proximity to each other, are electrically isolated from each other. So to give you a real world example that is probably more familiar to most students, an example of this is, and if you have anything that you don't care about and you want to cut open the wire of, go for it. Grab some, wire cutters or a wire stripper. Make sure that the thing that you're doing this to is unplugged because I don't want to be responsible for anybody getting electrocuted. And go ahead and cut a wire and look at how it's insulated. So what you'll probably see is on the outermost covering, there is either a black or white plastic coating. And then if the wire has individual component signals, like audiovisual wires are good for this because they have multiple places that are going to different things. So like there's the visual signal that goes one place, there's the audio signal that goes somewhere else. So if you cut one of those, what you'll notice is that after you get through that outer layer, the inner parts of the wire are insulated with their own color of insulation, which is also plastic. So that would be analogous to our perineurium. And then at the most basic level, each individual little wire, depending on what the wire is doing, is going to be insulated from its neighbors. So the idea is the same as here, which is that in household or technological electrical things, what's happening is that metal is conductive, meaning that if I disturb the electron density of one area of the metal, that change will propagate down the metal. But if that metal is touching a neighboring wire, that produces something called a short circuit because the conductive materials are touching each other, and that means that the stream of electrons doesn't make it to its destination because it's trying to go over the intersection of the wires to the opposite wire. So this is why we insulate our electronics. We want to contain that stream of electrons so that it goes where we intend it to go, to power our objects, to provide a visual or audio signal, to provide information of some kind. So this is all of our home electronics work this way, and the schema of coverings is almost identical to our actual coverings, which is pretty neat. Okay, so spinal nerves. A spinal nerve is defined again as when the dorsal root and the ventral root join up. Almost immediately after that, they branch out again, and a branch is called a ramus because this is just Latin for branch. So ramus is singular, rami is plural. So in this transverse section of the thorax, what you're seeing is some muscles of the back, and then the intercostal muscles between your ribs. And what you can see is that the spinal nerve immediately branches into the dorsal ramus, which innervates the back muscles and also the skin of the back for somatic senses. And the ventral ramus innervates the intercostal muscles and also the skin of the lateral and anterior thorax for sensory purposes. So this is just reflective of our body plan. We have to innervate both the front and the back, and so there has to be a dorsal and ventral ramus. And then this image from your book is just showing you the posterior aspect of all of the spinal nerves, and you can see that the intercostal nerves are relatively short, and then we have these kind of braid-like networks of nerves where we have to communicate with an appendicular limb, so an arm or a leg or a neck. So I'm just going to go ahead and bring all of these text portions to the front because I'm just going to run through them. So I already mentioned that ramus means branch, so the plural of that is rami. So dorsal ramus is also the same thing as posterior ramus, so they're used interchangeably. You can use either, but the effectors, meaning things that are subject to motor control, are the deep muscles of the back. So these are things like your erector spinae, which are the columnar muscles that run up and down on either side of your spinous processes and help you do things like maintain your upright posture, arch your back, etc. And then the receptors are the skin of the dorsal trunk. So your trunk is, of course, your torso, and the skin of your back is innervated by those. The ventral ramus, the effectors are the muscles of the anterolateral trunk. So anterolateral means front and side, and also the limbs. So we'll get into the limbs later. And then the receptors are the skin, so somatic sensory apparatuses of the anterolateral trunk and limbs. Rami communicantes, which is plural, by the way, so in Latin, if you're pluralizing the first part, you have to also pluralize the second part. So rami communicantes means the branches that are communicating. So this is what, and I know it's not super clear here, but what you can see is from the spinal nerve, the ventral root branches, and then coming off of the ventral root is this little connector piece that goes forward, but within the cavity instead of on the back. So these are for visceral effectors, so any effector that's not skeletal muscle, and for visceral receptors, which are receptors that are mostly things that don't rise to our conscious attention. So pH, ion concentration, chemical composition, pressure, gas composition, those kinds of things. Those are going to be visceral receptors, and these are going to be in the ventral cavity. So in this case, the thorax, and then inferiorly, the abdomen. There's also a meningeal branch, but it's not visible here because it's very small. And this is an FYI, so this is not something I'm going to test you on, but it is worth mentioning just because the meninges, of course, are your protective layers around your CNS tissue. And so it would make sense that they have some sort of motor and sensory apparatuses. So these are just innervating the vertebrae, the vertebral ligaments, so the ones that connect your vertebrae to each other, any spinal cord vessels, of which there are several, and also the meninges themselves. So moving inferiorly, so from the T2 to T11, because the previous one was general distribution. Now we're getting a little bit more specific. So we have a little bit of recapitulation here. So same stuff. And here we have a diagram of sensory input. I'm going to quickly move forward to motor output rather. And what you're going to see is that, oops, it does not want me to go back. There we go. So sensory input, remember our same Dave acronym. So sensory equals afferent, dorsal equals afferent. We notice that things are coming in from the dorsal, or coming in through rather the dorsal root ganglion and the dorsal root. And these are obviously going to be divided between visceral sensory and somatic sensory sensations. And then motor output is going to be to skeletal muscles and then anything else. So we'll get more into this when we get to the autonomic nervous system, because of course basically the autonomic nervous system is kind of gets its own chapter because it has its own arrangement of things, and it's just complicated enough that we kind of treat it separately from the somatic nervous system. So what we're going to notice and take note of is that, first of all, exteroreceptors and interoreceptors are present in both the dorsal ramus and the ventral ramus. So exteroreceptors mean detecting stuff that is information coming from outside of the body and or the very edge of it. So external stuff. So for this area, it's proprioreceptors, meaning the Golgi tendon organ and the muscle spindle of the muscles of the back and the skin sensors of the back, which are going to pass through the dorsal root ganglion. That's where the cell bodies live, and they're going to synapse on cell bodies that are in the top of the dorsal gray horn, because that's the location where the cell bodies of somatic sensory neurons live. Going ventrally, we have interoreceptors of body wall and limbs, so blood pressure sensors, pH sensors, mechanoreceptors, etc. These are visceral sensations. In the ventral root, those things are coming in from the body wall and the limbs anteriorly. And then we also have afferents from the back, and that's going to be from interoreceptors of the back. So our visceral sensations from the back, which are going to be the same set of things. So essentially, what is the diameter of our dorsal blood vessels? What is the gas composition of our dorsal blood vessels, etc.? So that information is also going to come in. Those two sets of information, the visceral receptors, converge at the spinal nerve area, and then they have their own cell body in the dorsal root ganglion, and then they are going to project axons into somatic sensory nuclei, which are just below, or excuse me, visceral sensory nuclei, which are just below the somatic. So there's a population of cell bodies here that are receiving somatic sensory information, and there are a population of cell bodies here which are receiving visceral sensory information. So the dorsal horn is all about sensory input, but the populations of nuclei are divided according to whether they are somatic and therefore rising to conscious sensation at least some of the time, or visceral, which means part of body regulation and the autonomic nervous system, and therefore not rising to conscious sensation most of the time. The one thing that we also need to consider is we have interoreceptors, so internal condition receptors from visceral organs that are going to be traveling afferently, again, through the sympathetic ganglion. So they're not synapsing here. And they're going through the rami communicantes. So those are these two rami. There is a gray one and a white one. Afferent information typically comes in from the gray one, or excuse me, the white one. And so that's also going to converge here. So this is going to be things like, since we're in the thoracic region, what's the pH of my stomach juices? What state are my smooth muscle organs in that area in? Are they contracted? Are they relaxed? What's my blood pressure like? What's my heart rate like? Those kinds of things. So we'll get more into that when we get to autonomic nervous system. So as to destinations of motor output, remember motor equals efferent. So this is information that is originating in the CNS, and it's essentially commands running from the CNS, which is the commander, down through the spinal cord into the peripheral nervous system, which is where effectors are innervated. So similar to the dorsal horn, in the ventral horn, the visceral motor nuclei and the somatic motor nuclei are separated, which means that we have cell bodies for visceral motor control, which is any effector that is not skeletal muscle. And then in the ventralmost region of the ventral horn, we have somatic motor commands, which are, of course, our skeletal muscles, which we are experiencing as mostly voluntary. So, as I mentioned in lab, there's a reason why the dorsal root ganglion does not have an equivalent structure in the ventral roots. You notice there's a dorsal root and a dorsal root ganglion. There is not also a ventral root ganglion. There's just a ventral root. So the reason for that is sensory neurons tend to be unipolar, which means they have a dendrite, which immediately gives rise to an axon, and then the axon is very long, and it extends past the neurosoma, which sits offside of the axon on a little stalk, kind of like a lollipop. So if we're going to have a bunch of those running in parallel, it makes sense to stick all of the cell bodies in the same location. And then the axons converge after that, and they just go ahead and synapse on either here or here. For motor control, if we know that the soma of multipolar neurons is the receiving end, because it's the end with all the dendrites, it would make sense for motor commands to descend in the white matter synapse on these cell bodies and excite these cell bodies for motor control, and then that signal originates from these cell bodies and exits via the ventral root. So we don't need to have a ventral root ganglion because the cell bodies here are just sitting in the gray matter of the spinal cord. There's no need for an exterior ganglion in this case because of the synaptic nature and direction of the signal. So that's why we don't have a ventral root ganglion. That's also very convenient for students because it makes it very easy to tell dorsal from ventral, because if you see a ganglion, automatically dorsal in this case. No ganglion, ventral. So that clears things up a lot. Okay, so we know that the dorsal root is afferent and the ventral root is efferent. And then when it's a spinal nerve, which is where those two things converge, it's considered mixed, meaning it's carrying both afferent and efferent information. but it only stays that way for a short time before it splits again into the dorsal and the ventral ramus. So what you're going to notice is that the dorsal ramus contains both somatic motor and visceral motor fibers that are going to innervate, respectively, the skeletal muscles of the back, so your erector spinae, your other large muscles of back, and also control effectors in your skin. And then the ventral ramus is kind of the same deal, but just anteriorly. So skeletal muscles of body wall. So these are going to be things like your intercostals, your external obliques, etc. And then for autonomic stuff, visceral motor, smooth muscles, glands, adipose tissue, any effector that's not skeletal muscle. So we've divided these images into motor and sensory in the previous slide, but it's important to note that all the structures are the same. So what that means is that within the dorsal ramus, these fibers are carrying efferent information. What's not pictured here are the afferent fibers, which are also traveling in this ramus. So they're not separated. It's just easier to separate them in images so you can make sense of it visually. So you'll notice that we've crossed out white and gray ramus here. We'll get to that later. This is for chapter 16 stuff, not chapter 13. So stay tuned for that. But what you will see is the rami communicantes, which means communicating rami, and those are going to contain myelinated and unmyelinated fibers that are going to basically allow the spinal nerve to communicate with the sympathetic ganglion. The sympathetic nervous system is your fight or flight system. So this ganglion is specifically in place to permit communication between your fight or flight system and the rest of your body. So if we look at what comes through here, we can see that the visceral motor nuclei send out axons that synapse on the cell bodies of a sympathetic nerve. So that's this cell body right here. And then the sympathetic nerve, which this is actually a sympathetic ganglion, so there's many of these, we're just showing one, that sends output both to the dorsum and the ventral ramus and also to the sympathetic nerves themselves, which innervate the inner body structures. So again, if you're curious about this and you're like, why aren't you explaining this thoroughly? It's because it gets its own chapter. So I'm giving you an intro here. I'm not going to go do a deep dive because we'll get to it later. And all similar deal for postganglionic and preganglionic. If these words aren't making sense to you yet, that's okay. We'll explicitly describe those terms when we get to the autonomic nervous system chapter. But the idea is the same. So we see smooth muscles, glands, visceral organs. So this is going to be, of course, visceral effectors. And then we've got a division between thoracic cavity and abdominopelvic viscera. So it's just a structural division. All right, so this brings us to dermatomes. So derma means skin, and tome means page. So what dermatomes are the given area of the epidermis and dermis that provide sensory input to a given spinal nerve and its corresponding spinal cord segment. So what you're seeing here, and this is like divided down the middle between the anterior view and the posterior view, is how those things are divided up. So this matters for a variety of reasons, but one of them is because many of you are going to go into nursing, and some of you might choose to be nurse anesthetists, and that's a very lucrative field of nursing. Being a nurse anesthetist requires extra training above and beyond your nursing certification, but because you have more responsibility, you make more money. So just something you should know. One thing that an anesthesiologist and a nurse anesthetist have to worry about is, let's say you're doing a procedure that does not require that your patient gets general anesthesia, so they're not knocked out, we're just going to numb them up in the area that we're doing the procedure on, and that should be good enough. So here's the deal though. These regions have overlap. So let's say I'm going to do some procedure in the region of T8. Maybe I'm going to do like a, I don't know, Mohs procedure where I take a biopsy of a skin section because of suspected skin cancer or remove a skin tag or some other thing. And I don't want my patient to feel that, so I'm going to definitely numb the area of T8. But in order to avoid pain leaking over, I'm probably also going to numb up T7 and T9 just to make extra sure that my patient is comfortable. So if I'm administering topical anesthetic or local anesthetic, I need to be aware of the dermatomes to accomplish my buffer zone. So I just make sure that like I've covered enough ground dermatome wise that I can be as sure as I can, barring general anesthesia, that my patient is going to be nice and comfortable and not feel anything. When we get to some other sensory stuff, I'll talk about referred pain. The short version is referred pain is when sensation in one area, typically a visceral sensation like chest pain, etc., is perceived as a superficial pain in one of the dermatomes. So the one that most people are probably familiar with is that, one of the signs of a heart attack is pain that radiates up and down the left arm and shoulder. And then shortness of breath and other things are also co-indicators. But the reason for referred pain, which is where the area that feels painful to the patient does not match the area that's actually experiencing tissue damage, is because sensory input from the dermatomes at a given spinal segment is going to come in alongside visceral sensory input, and sometimes the signals get crossed. So more on that later. Okay, plexuses. These are braid-like networks, and in fact, that's what plexus means. It means a braid. So these are braid-like networks of nerves that innervate typically a limb. So this particular plexus is the brachial plexus. Brachium means arm. So these are the nerves that are going to innervate your brachium, which is your upper arm, and your antebrachium, which is your lower arm. So these provide innervation, which means nerve supply, to the neck and the limbs. So you have a cervical plexus, and then you have a brachial plexus and a lumbar plexus, and also a sacral plexus. So these are networks of interconnecting nerves, as you can see here, and that makes them inherently confusing because they have this interconnectivity that goes, well, I'll show you a closer view, but basically like when they branch off from each other, they often reconverge, and then one branch goes anterior or superficial and the other one goes deep. So it makes them just, annoying to learn. But the outcome is that you have adequate innervation of all of the structures that you need to both sense and provide motor control. So one unifying concept of the plexuses is that they're formed by the ventral rami only. So you don't have any plexuses formed by the dorsal rami, it's only ventral. And this is from 4 specific regions of the spinal cord. So cervical, meaning neck, brachial, meaning arm, lumbar, which corresponds to your lumbar spine, and then sacral, which corresponds to, of course, your sacrum. So you can see that the cervical plexus goes from C1 to C5. The brachial plexus overlaps, going from C5 to T1. And if you're wondering, why does it overlap? Well, the ventral ramus at C5 branches again to provide both an upper branch that goes to the neck area and a lower branch that supplies the brachial plexus. And then we skip most of the T-spine because these thoracic nerves are going to innervate the intercostals, and this is a special area for a variety of reasons. The lumbar plexus starts at T12 and goes down to L4, and then the sacral plexus does include the last two lumbar vertebrae as well as everything down to the very end of the sacral spine. So these are going to provide innervation to the corresponding body regions. So one thing to consider clinically, as far as relevance, is if you have a spinal cord injury and it's severe enough, one thing you'll have to worry about is knowing the plexuses and knowing the ventral ramus innervations for those plexuses, and therefore what senses or motor functions would be affected by that particular level of spinal cord injury. So obviously, cervical plexus injuries are pretty bad because everything down from that is kind of dead. Um, so that would be a Christopher Reeve type situation where he's the guy that played Superman and he was riding horses and he got thrown from a horse and he broke his neck and was in a wheelchair with a ventilator for the rest of his life. But then anything down from there, basically you're worrying about loss of function from the area that is broken down. Okay, so the cervical plexus, meaning neck, so this is a picture of it. Now, I want to stress, this is not a hardcore neuroanatomy class, so I do not expect you to memorize this structural arrangement. If you were a neurosurgeon or a craniocervical surgeon, I would expect you to, but that is not reasonable for this class. So don't look at this and freak out. Just be like, oh, I'm so lucky that I don't have to know that. So this is just a picture to show you what it includes. But the most important cervical plexus nerve is the phrenic nerve. And that is because this nerve innervates the diaphragm. So your diaphragm is a dome-shaped skeletal muscle that is partially under voluntary control, but also partially not voluntary. This is why you can breathe while you sleep. And if the phrenic nerve on both sides, which you can see goes all the way down on either side of the pericardium and then innervates the diaphragm, if this gets cut on both sides, you no longer have the ability to ventilate your lungs, which is obviously a problem. So for some context on this, the virus, polio, is a virus that tends to attack and destroy nervous tissue, resulting in paralysis or partial paralysis and denervation of whatever set of nerves is affected by that particular disease. So the reason that during the American polio outbreak, we saw a lot of patients, most of them children, relying heavily on the apparatus called an iron lung, which is a big chamber where negative pressure in the chamber artificially expands the thorax to draw air into the patient, and then positive pressure in that chamber pushes the air back out of the lungs. The reason for that is because for those children, the phrenic nerve was damaged by polio and no longer useful, so they were never going to be able to ventilate their lungs on their own ever again, which is obviously terrible. If you're not squeamish and you are resilient to getting sad feels from looking at sad pictures, I would recommend going and looking at iron lung images. What you're going to see is rows and rows of iron lungs with little kid heads sticking out of them, and then typically nurses coming around and either feeding the kids or showing them pictures, or they also have mirrors they can see themselves and their neighbors. But not a fun thing. Fortunately, we developed a polio vaccine, which is a way to expose the immune system to the relevant parts of a virus for the immune system to learn it, so that if the person is then subsequently exposed to the virus, the immune system is like, I know that guy, get him. And it cuts the virus off at the pass before it has a chance to make us sick. So the reason I'm being explicit about that is because we are experiencing culturally a shift back towards a belief that vaccines are dangerous or somehow ineffectual or some kind of a science lie or not real. And there's a variety of reasons for those mistaken beliefs, which I won't go into here, but those are very, very dangerous for the population because it means that we are seeing a resurgence of diseases which are preventable and or treatable via vaccines at the population and individual level, but require herd immunity where the majority of people need to be vaccinated in order for that to be effective at the population level. And people that choose not to get vaccinated are endangering both themselves, most of all, in fact, and unfortunately, but also other people. So I'm not here to debate vaccines with anyone, certainly not my students, and also not anyone who happens upon this lecture on YouTube. Um, for you who are arriving at this lecture not from my class, I am under no obligation to engage in debate with you over the internet because I am not paid for it and I don't have the time or the energy. So don't even comment. Thank you. But for my students, if you have any questions about what I just said, feel free to come ask me. I will provide you with a judgment-free explanation just so that we can all be on the same page about what those things mean. Okay, so this is a picture of the brachial plexus. I'm not going to read this slide to you because, like, boring. What I will say, though, is that if you have had the lifelong experience of having arms, like I have, you may have noticed that in certain positions, certain portions of your hand or arm tend to go numb. So the most familiar example that I can think of is you'll notice this region in pink down here that's innervated by the ulnar nerve. So if we go trace that and we know that the ulna is always on the pinky side, so we can go like, okay, so like that must be here. We'll notice that the ulnar nerve dips back behind the trochlear notch and the coronoid and olecranon process of the ulna, and we know that the olecranon process ends in the olecranon fossa behind here. What it does is it actually goes back around the olecranon and then back medial. So if you are laying down in bed and you have your arms and your elbow joints flexed, that ulnar nerve is pretty pressed up against your ulna and your humerus, and it has pressure on it, which decreases the oxygen availability. So over time, due to that position, your ulnar nerve will become numb. And what you'll notice is that if you kind of check in with your hands and you're like, okay, well, my hand's going numb, but only part of it, what you'll find is that your pinky, your palm, and part of your ring finger is numb. But if you just go ahead and extend your elbow joint, that numbness goes away. So it's always nice when we can prove to ourselves that the things we're being taught in images and in the textbook are actually real. And so you can do that experiment yourself. Okay, so these tables in your textbook describe the distribution and innervation of each of these nerves. So these are fair game for your exam, but since for lecture exams you have the opportunity to use notes, what I would do is just either bookmark this page or make a Cliff's Notes version in your handwritten notes that goes over this so that if you need to refer to it, you're prepared to. All right, so for lumbar plexus, the major nerve is the femoral nerve. So femoral meaning of the leg. And so if we go here, we can see the femoral nerve is adjacent to the obturator nerve. So this is the nerve that innervates the muscles that occupy the obturator foramen. Genitofemoral nerve we'll come back to because this is the one that innervates the sensory and motor structures of the genitals for both males and females. So this is the one where if an injury breaks it, you no longer have sexual function. And then lateral femoral cutaneous nerve is what it sounds like. So it's the leg skin as opposed to leg muscle and leg sensors. So femoral nerve comes off as a result of a convergence between L3 spinal nerve and L4 spinal nerve. And if we sort of travel over to this, what we will find is that if we trace the same stuff back, so find L3 and L4. So we got L3, L4, and then this is the genitofemoral nerve. And we go down, what we're going to find is that it immediately branches into a bunch of stuff. So that's going to supply the rectus muscles of the anterior thigh. So these are the things that allow you to lift your leg and pick your knee up. And it also branches out to supply the medial portion of your leg. The sacral plexus, by contrast, has a major nerve that is the sciatic nerve. So that's going to be a confluence of nerves coming off of L4, L5, S1, S2, and S3. So that's a lot. That's why it's so thick. And we can see this both on the cadavers and on our spinal nerve models, but this is a very thick nerve. And if you look closely at the picture here, what you're going to see is that it runs between the greater sciatic, it runs, through the greater sciatic notch. And so through that portion of the os coxa, past the ischial tuberosity in that little curvature, and it's going to innervate your posterior thigh muscles and also innervate all of the muscles of the lower leg in the back. So the condition called sciatica is a condition where pinching or peripheral diabetic neuropathy or a herniated disc irritate the sciatic nerve, and that tends to result in radiating numbness, tingling, pins and needles, and pain of everything down from the sciatic nerve. So you get these pains that run all the way down your leg and down to the bottom of your foot. Very unpleasant. So you don't want to damage your sciatic nerve because that results in a pathology which is very difficult to live with. All right, so now that we're getting into neural integration patterns, I'm going to stop this video here just so I can upload it. And then the next video will concern details of ultrastructural aspects of how neurons talk to each other. So we've already talked about synapses, but we haven't talked about how the synapses can be arranged. That's what this picture is showing, and we'll talk about the consequences of that in the next video. So, as always, thank you kindly for your attention and dedication to the class, and I will see you in the next video.